So it's a good segue into the future direction. So we've heard about the 1.0 and the 2.0 and, you know, Ted's projection that it's going to keep going, and at some point we'll have the Apple iWatch version of OCM. But pending that, what I want to maybe go down the line, but what would be the one thing, if you could get it tomorrow as part of OCM, what would you like to see different than what it currently is?
Well, I think you know, I have to say one of the clear successes of OCM is engaging more of the stakeholders in this discussion for value, even just beyond the economics of it. Again, how can we make the experience better for patients? And so, to be honest, that's how we're approaching it at our center. And this is part of why we wanted to be engaged from the onset, because this was just one means for us to kind of advance that end. And so I do agree there should be an OCM 2 and 3 and 4 and 5, because in my mind there have already been successes. It's not perfect at all, no. But there has been progress, and I think the model, the idea of the value-based pricing is critical. What I would like to see is just a continuation of this and a continual evolution of this.
All right, Kavita, top thing?
All right, my top thing is that we know the MIAS payments have worked because everybody pretty much unanimously says that. Monthly payments to help kind of pay for these coordination and services doesn't adequately do it, but it does.
Well, it only does because that was a requirement. So you could have required the IOM 13,
yes,
but nobody would have done it.
Correct.
So now we'll give you this if you do that.
Right. So I agree with you, Bruce.
I agree that.
But it was a very attractive way, especially for a physician who doesn't have like the ability to get a deep line of equity and just pay for things. It's a way to keep your practice running while innovating. Monthly payments that doctors really have said have been extremely helpful to manage kind of day-to-day practice expenses that they otherwise could not manage. And then actually combine that to Ted's point about price prediction. Let's just have like some agreement that Medicare went into this to, quote, save money. Let's take the aggregate dollars across all the doctors that we think, and I've looked at these numbers, right, that if we think that we can save somewhere around $100 billion per year in cancer care by being in a better model, let's take that dollar amount and then actually say, let's divide it amongst kind of the numbers of physicians who are taking care of patients, and actually just give you kind of almost like a global budget and say, you know what, Bruce, you don't have to do IOM, but you kind of need to do these basic things. We're not going to micromanage what those are, but you do them and you deliver them the way you want to. In your rural community in Texas, it might be through like lay navigators trained at the church. In urban Baltimore, it might be some other model, but don't prescribe it, let them do it.
So do you bring up those examples specifically because small and rural practices have really struggled under OCM?
Yes, but not just under OCM, under every alternative payment model, because you can't, there's no, CMS and also many even small payers tend to take this cookie cutter, like, here's our payment model and drop it on people. And then, passive doctors, we just kind of are like, we'll take it, that sounds great. Right. Why not flip the script a little bit and let people innovate? All care is local. We can unanimously agree, all care is local. Let us innovate locally, but be held to metrics, so they're not wasting taxpayer dollars.
All right, so I know I can't limit you just to one, but I'm going to make it be your top.
I'll give you one.
All right.
Well, I'll give you three, and then I'll give you one.
I knew it. See, I was going to even give him the three, but he wouldn't give me a chance. You're going to be bold.
Price prediction, risk adjustment, but what I'll give you is attribution, which means basically that the correct patient is attributed to the practice. Right now, there are too many false positives and negatives. What do I mean by that?
So you mentioned Florida Cancer, and they're 9% of the total because of their size, and they've got the snowbird population.
Right.
How much is attribution an issue everywhere else in the country?
Huge.
Attribution is a huge issue.
Huge everywhere?
It started out as 40%, literally 40% error rate.
Huge.
Both in terms of a negative and a positive. Because you have to understand this, Bruce. You're talking about claims data, okay? So you're talking about attributing I've heard this over and over again, that a patient basically, let me simplify it, patient is being treated and they're on follow-up, basically all they are is a cancer follow-up, so they basically E&M, they've had drugs, but all of a sudden slips and falls and ends up in the hospital has nothing to do at all with their cancer. I'm not talking about a break attributed to their cancer, bone cancer, or anything like that. I'm talking about somebody goes into the hospital, they have surgery, expense, and all of a sudden, the oncologist gets attributed to that patient. That patient gets attributed to the oncologist. That doesn't make any sense. And I can tell you right now, as Kavita well knows, there are too many false positives and too many false negatives. Patients that shouldn't be attributed to the practice, patients that should be attributed to the practice that aren't. So this is a big issue. So as much as I said, risk adjustment, price prediction are issues, this is a fundamental issue, because if that's how you're getting paid, if that's how you're measuring quality, and the patient really isn't yours, or the patient over here should be yours, that's a problem.
All right, Susan, last word on the what you'd like to see different. Your number one first choice of 2.0.
Well, I think I'd like 2, since you got 3.
Absolutely. You get. Forget about Bruce. You got 2. Go on, Susan.
I knew I was done.
Yes, and I can't be upstaged there. So first, I think practices need information quicker and faster. Having lag time on their data doesn't allow them to make changes in any meaningful way. But even more important than that, do we ever talk about the human being and the patient behind all of this, right? And in the busyness of clicking boxes and meeting KPIs, I think that what often gets missed is the human, right? And you talked about it a little earlier. What does value even mean, right? And do we attribute their value when we're making treatment decisions and when we're offering full-scale care? And that is the one thing that I still think is behind, because it has taken so much work for practices just to get the infrastructure in place to be able to collect data and report data and then understand their data, that we still have forgotten the human, which is why we went into this care in the first place, right? So I guess that's my number one.
And let me just sort of dovetail off of that and say that, look, let's talk reality now. The whole idea, and I take nothing away from CMS, the CMMI team, the OCM team has been fabulous working on this and has been dedicated to it. But from a big perspective, this is about trying to save money. This is not about trying to do a better job delivering cancer care. It's from the perspective of the government, how do we save money? And that's a little bit of a problem, because when the focus is just on...
I'm not defending anyone, but just the point could be made that there is a significant component of that government think tank, which is that if we improve quality, we will save money.
How often has basically the government made a change in either the reimbursement system or something related to money? Kavita can tell you this a lot better than I can, that has had an unintended consequence, which has actually cost money and actually lowered quality. So the problem is, I'm not unduly criticizing, I'm just saying these are the kind of things we have to think about. In fact, what should happen right now, what from the CMS perspective, CMMI perspective should be happening, we're certainly gonna do it, is taking all this wonderful learned knowledge that the practices have literally transformed and say, what have we learned about this? What have we done in terms of making cancer care better? Yes, the money component is important. Yes, the price of drugs is critical. It's unsustainable on its current trajectory. But what can we learn and what should we do differently? That has to happen as well, too. And sometimes, although the OCM team has done a great job, CMMI as the innovation center, but sometimes government and literally the providers don't exactly meet, because you also get in these stupid legal and regulatory regulations that keep them apart.